So let's get started on our positioning. So after this module, you'll be able to identify the criteria for a good mammogram, evaluate both the CC and the MLO projection. Those are the routine projections, but we'll also go into some of the supplementary projections, reasons for these, and an evaluation of these supplementary projections. We will take a look at quality standards in mammography, the standard supplementary projections, and then we'll also go in a bit on troubleshooting image quality. So what is mammography? It's actually one of the most performed studies for diagnosis of breast cancer. So the screening mammogram, the 2 projection series screening mammogram, that is the CC and the MLO, that is what's most often used in screening. If there is a problem, then we may move into the diagnostic, and the diagnostic mammography is when we may bring in some of the supplementary projections. So let's take a look at some of the standards and some of the image quality features. So before you sign off on your mammogram, you need to be able to demonstrate a high quality image. Remember, if you have not imaged the part, then there's possibility that the radiologist will miss that cancer, and that patient's cancer is going to go on undiagnosed. So there are a few steps that we as technologists should take before we start the case, during the case, and as we end the case. First, we have the documentation of patient history. So we need to take a very clear history from the patient, signs and symptoms, anything, abnormalities, any visible abnormalities of the breast we need to document. And these could be moles, these could be scarring, these could be any type of surgery, anything unusual in the breast. Take a look at the nipple. Is it inverted? And then you question the patient, is this normal for this patient, or is this something that recently started? So that you also check with the patient. If it's a screening mammogram, there should not be a palpable abnormality. So that will move it into the diagnostic range. So for screening mammogram, the patient should say that, no, I have nothing, I didn't feel anything, and then you can go on with your screening. So some of the surgical things that you should be checking your patients for is, did they have a needle biopsy or any type of surgery? And just be careful sometimes when you ask the patient if they had surgery, they may actually have done a biopsy, so you need to be exact. And the term lumpectomy can sometimes be confusing for patients too. They may think that a lumpectomy is any type of surgery on their breast. So in those cases, you may make sure you follow up with questions to the patient to get an exact answer. Type of aspirations, this is the type of surgery that the patient may have where they simply had an aspiration done. Again, you want to make sure that you are exact. Mastectomy, one or both breasts, again, make sure this is properly documented. If the patient has had any type of radiation treatment, typically if the patient has had recent radiation treatment, you may not necessarily want to have an immediate mammogram. So this is something you would have to check with the radiologist, find out how soon after the radiation treatment do they want to have the mammogram. Another thing to check is for any type of implants. If the patient had, most of the time, the implant can be either saline or silicone. That has to be documented, but it could be a transflap. Again, the policy of your facility, maybe you can image the transflap or maybe not. So these are some of the things that you need to document. In terms of the patient's gynecological history, age of menarche when they had the first period, if in menopause, age at menopause, pregnancy, how many pregnancies when they had the first pregnancy, the number of pregnancies, all of these can affect the appearance of the breast tissue, so all of these should be documented. If it is a late pregnancy, the first pregnancy is a late pregnancy, this is also something that needs to be documented. And any type of gynecological surgeries, uterus removal, ovaries removal, any of that should also be documented. In terms of labeling the image, there are standardized labels that should be followed, and you need to make sure that all of your images are labeled. Most of the time with digital imaging, that's not actually a problem unless there's something major wrong with the equipment. But some of the things that should be done for your label, in terms of labeling, you should have the patient's name plus additional identifier, such as an MRI number or the patient's birth date, the date of the examination, of course, the projection and laterality, and that is usually placed in the axillary area of the breast, the facility's name plus the address, some form of mammography identification. Mammography identification could be simply the initials, and then it has to identify the unit, especially if there's more than one unit at the facility. You need to be able to get high quality imaging, and high quality imaging, of course, implies that you are assessing your image, which I will go into a little bit later, and there's no motion. And then I'll also go into a little bit of on the supplementary projections. One other thing I need to mention in terms of your documentation of history is if the patient has any type of nipple discharge, that should be documented, the color of the discharge, the duration of the discharge. Typically, if a discharge is clear fluids, white, it might not be of significance. Of course, you could still mention it, but any type of discharge that's brackish, bloody, brown colored, that should definitely be documented. If a discharge occurs spontaneously on compression, that could be mentioned. But again, if it's clear, liquid, white discharge, that might not be of significance. And hormonal history, if the patient is on any type of hormones, how long, the length of time when they started, birth control pills, that should also state the duration, how long when they started. This is all a part of the clinical documentation. If the patient had breast cancer surgery and they're on any type of treatment, for example, tamoxifen treatment, that should also be mentioned in your documentation, both the start date of the treatment and the duration of the treatment. Now, the criteria for positioning. A lot of the criteria for positioning with digital is, you could almost say, fixed. The contrast, the density with automatic exposure factors and techniques, those are fixed. And if something goes wrong, you would call in the inspector, the service personnel in to check. But two things that are still within our control is the patient positioning and the compression. And these we need to absolutely optimize in order to maintain high quality imaging. So you need to make sure that you're showing as much of the breast tissue as possible. The imaging of the breast is maximized by the compression techniques. You need to be able to compress all of the breast tissue, and the breast is typically compressed until it is taut. So the criteria for your CC projection, I'll go back to the criteria. Let me just talk a little bit about the position first. So the good, you compress the breast until it's taut. Typically, I'll make a fist, I'll double my fist, and I'll just touch it and tell the patient, this is what I'm trying to achieve. So you announce it. Oftentimes you want to keep your hand on the breast tissue, pulling it in until it's replaced by the compression paddle. Another reason for doing this would be the fact that the patient sees your hand in the compression area, and they're not as scared that you will be indiscriminately compressing on their breasts. The guidelines for breast compression stated by the MQSA it's not the maximum that you should apply to every single patient. So you should assess your patient and judge that compression. Again, it should be until it's taught, but you're not going to go to the max just because that's the standard set that by the MQSA. That is the equipment check, not to be applied to each patient every time. The communication with your patient is critical. There are some newer mammography units that offer self-compression. And what I've actually found that patients will compress even more than you will even imagine if they understand how important the compression is. So the communication is really critical in ensuring good compression. However, if the patient is extremely sensitive, while we cannot prescribe pain meds for the patient, we can give them suggestions and suggest that they consult with their physician about any type of pain relieving meds. You can also do planned scheduling. The breast is going to be most sensitive at the point of ovulation. So if you can try to have the mammogram scheduled before that, within those first 10 days of the period, that would help some patient. Again, with patient assuming control, just make sure that patient understands fully the nature of compression, the reason for the compression, the importance of compression before letting them have control. So the main reason for the breast compression is the fact that when the breast lays on the detector, it's going to be an uneven density. So you want to have a uniform density for the radiation to go through. But there are other reasons. It actually will compress the breast so there's a narrow area that the radiation has to travel through. This is also going to reduce the radiation dose to the breast. And with that will actually bring lesions closer to the detector. It reduces any possibility of motion by having that breast firmly compressed in the unit. And by decreasing the thickness of the breast, you also increase the contrast and reduce any possibility, any scattered radiation. And just the compression itself will separate superimposed tissues. So all of these are valid reasons for compression. But as I mentioned, the main reason is actually the fact that it gives you an even density for the X-ray beam to pass through. So here we have showing compression, good compression, insufficient compression, and compression that might be a little bit too energetic. Again, you are going to assess each patient. You don't get the same compression for everybody. You're going to assess each patient and give compression until the breast is taut. But if the breast is very painful, then you need to stop, find out why before possibly resuming or possibly rescheduling that breast exam. So now we just go into some of the general rules for the standard CC and MLO projection and how we ensure that we have full breast tissue on all of our mammograms. So the two projections, CC and MLO, are actually complementary projection. What this means is that missed error on one will not necessarily be missed forever. It may show up on the MLO. If you miss it on the CC, MLO, and MLO on the CC, or vice versa. But you need to remember what is important for each projection. For example, the CC is going to demonstrate the medial breast tissue, and it's only the area where the medial breast tissue is going to be demonstrated without distortion. It is demonstrated on the MLO, but it's an oblique, so that area, the medial and central breast tissue, will be distorted on the MLO projection. So we need to make sure we get the medial projection on our CC. So we have the patient should be facing the machine, facing front. You don't want the patient to be even on the floor, feet flat, and try to have them turn their head away from the side being examined. If they turn it to the side being examined, it pushes them away from the unit, and then you end up with missed breast tissue. So the criteria, once you have imaged your breast in your CC projection, make sure that you have good contrast. It shouldn't be looking washed out. You need to have nice, sharp, defined details. The nipple should be centered. If the nipple is not centered, typically the nipple is going to point in the direction of the missed breast tissue, so that you can check if you're missing breast tissue on your radiograph using that criteria. So you need to get the full medial and lateral tissue within the collimated field. If at the lateral aspect of the collimated field, you're not seeing the retromammary space, then you know breast tissue extends back into the posterior portion of the breast. That's possible missed on the CC. So you may need to do an additional projection. That would be the XCCL, which I will describe later. You can sometimes see the pectoral muscle. Typically in about 30 to 40% of the cases, you will see the pectoral muscle. But if you're seeing it on every single one of your CC projections, then you know you're doing something wrong. You're probably turning the patient and pulling too much lateral tissue into the collimated field. Again, you must see that retromammary fat tissue on the posterior aspect to know that you have imaged all of the breast tissue. And when you measure the CC, it should be within 1 centimeter of the PN line on your, as measured on your MLO projection, which I'll describe in a little bit. Dense areas, of course, should be well penetrated, and there should be no artifact that is obscuring any type of details on your image. And when you compare your CCs, they should be basically almost mirror images of each other. For the mediolateral oblique projection, typically the patient is going to stand with their side to the X-ray tube. Typically you want to form this nice 45-degree angle between the patient's arm and the patient's body to ensure that they're flush against the detector and there are no spaces, no gaps. You need to support the anterior breast. If you're not supporting the anterior breast, it's going to droop when you're compressing. That will give you that drooping anterior breast look that you want to avoid. So you need to support the anterior breast with your hand until the compression takes over. The detector angle. I know a lot of techs like 45 degrees. 45 degrees is actually telling your patient that they need to do some form of gymnastics and fit in the unit versus readjusting the unit to the patient's body type. So you look at the patient's pectoral muscle, and to maximize visualization of that muscle, you're now going to angle the detector to match the angle of the patient's pectoral muscle. So that can range, it can go anywhere up to 30 through 70. Typically for taller patients, it's approaching the higher numbers, and for male patients in particular, it may be at the 70. For average patients, you may be in the 50s to 60s. Typically, I would sometimes do a patient who is shorter, heavier set. I may use a low angulation just to have control of the anterior breast tissue when you're compressing, and also to get an open fold. So once you've completed your MLO, you're going to take a look at it. And of course, you need to have got good contrast. The skin folds should be minimal. There should be no folds in the inframammary fold. If the patient is heavy, typically when you have to lift the breast to get an open inframammary fold, you might create a fold in the axillary area. Again, you need to examine that radiograph, determine is it something that is going to impact the diagnosis, and you may need to do AT axillary tail projection to open up the fold in the axillary area. But again, that's an assessment that you'd have to make. And depending on your facility, some facilities suggest that the tech do this automatically, whereas others, the patient might need to be called back. The pectoral muscle should extend to, at minimum, to the level of the nipple. It should be convex to start, and then it tapers down as it approaches the nipple. Again, no artifact should obscure any of the anatomy. And when you look at both your MLO projections, there should be near mirror images of each other. So this is a measure of the PNL line. PNN line, of course, for the CC from the nipple all the way to the posterior aspect of the breast. If you have imaged any pec muscle, then you include the pec muscle in your measurement of the PN line. And for the MLO projection, you have to make sure that the line going from the nipple to the pec muscle is perpendicular to the muscle. And that is the measurement that you use for your PN line. So your arm should be straight. Your arm should not be raised higher or lower. You should go straight across at right angles to your body, and the detector should be right in the axilla. You should not compress the humerus. So you should be just below the head of the humerus. The head of the humerus should not be in the compression field. And then you're going to image from there. Your breast should include the entire your image should include the entire breast tissue with an open inframammary crease. Now, if the patient cannot fit on the detector, if the breast size cannot fit on the detector, then you will have to do sectional imaging, which I will discuss again in the second portion when we discuss supplementary imaging. If the pec muscle and the IMF are not visualized properly, do you automatically repeat the image? That is going to depend on how much, how close the inframammary fold is. Typically, you do want to have an open fold, but there are projections that will give you an open fold if it is severely overlapping tissue in your MLO projection. There are also situations with patients that it's next to impossible to get an open fold on your routine MLO projection. In that case, you might do one of the supplementary projections, for example, the Mediolateral oblique or the SIO, and get at least you have an open fold. So that's an additional image that you would submit with your routine. The same goes with the pec muscle. You do want to get the pec muscle to come down to the level of the nipple. However, if you don't, and you attempted to repeat that, and it's still perhaps because of the patient's body habitus that you cannot get it. So that is very possible. What you can do is look at the old images. How effective was it in the previous mammogram versus yours? Did you get a better image, or was yours worse? So this is one of the things that you can look at. But I do recognize that there are times when it is next to impossible to get the pec muscle to the level of the nipple. So you're going to make your best effort as a technologist. Is the MLO position, how do you define the correct height of the detector? Again, you're going to put your arm up, and the arm should be straight across the right angles to your body. It should be at angle down or higher, and then you're going to put your detector right in the axilla. In order to decide if a mass is upper or lower, to correlate this. Okay, so I will be discussing this when we discuss the MLO projection. How do you determine a mass location based on how it moves from the MLO to the ML projection? How to prevent the nipple from tipping downwards to the detector when doing the CC projection. Again, I'm going to be discussing these. So please hold these questions. I will discuss this when we discuss section 3. Any information on patient under 30 years of age, example 25, who has a family history and present with a breast lump for investigation. Now, imaging can be done on young patients. With digital, it actually has made it easier. In the past, if the patient's breast was extremely dense, as in a young patient, the imaging almost was meaningless. Digital imaging has made that a little bit better, but this is something that I would definitely discuss with a radiologist. If a very young patient comes, it definitely should not be just a screening mammogram. But if they come for a mammogram at age 25, cancers can develop in young patients. So it's not an automatic thing that you're going to say that you're not going to do this patient. It should be discussed with the radiologist. Ultrasound can sometimes offer an option, but again, this is a decision that the radiologist would have to make. With extremely large breasts, how do you make sure that the nipple is in the center position for the MLO position? For the breast tissue, when you're imaging the breast, the if the breast is extremely large, you may have to do sectional imaging. You want to make sure that you're absolutely getting the full breast, including the inframammary fold and the pec muscle. So if you're not going to see that on your single projection, even using the larger detector size, then you will have to do sectional imaging. Do you consider lumpectomy breast cancer surgery or lump removal? Lumpectomy is reserved only for breast cancer surgery where they removed a cancerous lump. So this is something that you need to be clarifying with your patient. If the patient said that they had a lumpectomy, you make sure you question them a little bit further and find out, did you have cancer surgery? Did you have cancer of your breast? Was there something removed? Versus, did you have a biopsy? Did you simply have an aspiration? Some patients just call any form of surgery that they had a lumpectomy, but make sure that you are defining it properly for the radiologist. If the patient said they had a lumpectomy, it should be that they had a cancerous lump removed from their breast. My question refers to the actual image. Evelyn asked a question. I'm not sure if I quite understand the question. If you could rewrite that question and submit, and I will get back to it. The next question, what is the relationship of the pec muscle and the PNN angulation? So let me go back to that slide. So here's the posterior nipple line. So the posterior nipple line goes from the pec muscle to the nipple, but it must be perpendicular. This angle must be a right angle. So you're using that right angle from the pec muscle and you're going straight to the nipple. So the pectoral muscle should extend at or beyond this point. Some facilities do a screening mammogram post-mastectomy. What's the suggested practice? That is correct. Some facilities do require you to image a post-mastectomy patient. I've done that in the past. Typically, most often, what I can get is an MLO, a limited MLO, yes, but an MLO. The reason why that's recommended because cancer can develop at the mastectomy site. Normally, the recommendation is that the area should be visually inspected or imaged. And most oncologists are moving towards a visual inspection versus an imaging. But again, it depends on the facility where you work and the recommendation of the patient's physician. What patient and mastectomy? When patient with mastectomy comes, is it desirable to do an MLO of the operated side to see if there's any residual in the pec muscle? As I said before, it's possible. It depends on the protocols of your facility. So this is something you would check with the radiologist for. I have done it in the past, imaged the mastectomy site, and I've also worked at facilities where they do not recommend that you image the mastectomy site. Normally, when I'm with a patient and they come in and they tell me that they've had a mastectomy and it is within the last few years, I'll immediately ask them, are you having the site inspected or visually checked by your doctor? So that hopefully that they will follow up in that way. Because like I said, you can have a cancer developing at the mastectomy site. If a patient had a mammogram done and a lump was detected, is it fair for the patient to just proceed to do a lumpectomy and have the lump tested afterwards, or is it recommended that a biopsy be done first? So if the patient has a lump in their breast, typically they would do an assessment first before any recommendation. So they may do an ultrasound, for example. They may ask for spot imaging, mag imaging. Once that workup is concluded, they may even go further with MRI to determine, is this something real? With 3D imaging now, that oftentimes gives the radiologist a lot more information. So depending on what is found, then the decision is made. Are we going to follow this because we think it's benign, or are we going to biopsy this because we think it's malignant? And that's what the conclusion that the radiologist will also often weigh. And if it is possible malignant, that's when the recommendation for a biopsy. Now, the biopsy could be either a fine needle aspiration biopsy, where they simply go in, take out cells, check it. It could be a core biopsy, where they take out tissue, or it could be an open biopsy. And the decision there depends, again, on the nature of the actual lesion. Is it something that is too close to the chest wall to be biopsied using core? Is it too deep? So both the surgeon and the radiologist will have to confer and decide what is best for the patients in that case. But typically, they don't simply go and take out a lump simply because the patient says they have a lump in their breast. Let's see. On the actual image, how do you determine where the line defines the upper and lower breast? So if you look at this MLO here, the lowest extent of the breast is going to be the inferior mammary fold or crease. The upper extent of the breast is going to be right below the axilla, where you have the pec muscle started. So if you say image the breast and all you're getting is the breast tissue and you're not getting any pec muscle above that, then you know you have not included the entire breast. If you're imaging the breast and you have clipped a portion of the inframammary crease, then you know you have not included the entire breast. In this section, we're going to talk about some of the supplementary projections, and this should answer some of the questions that we had earlier on how to get the MLO, ML, open fold, and what the reason for some of these projections are. So I'll simply go through them. And again, if you have any questions, please feel free to put it in the chat or put it in the Q&A box. So the lateral-medial. This is a projection. So the direction of travel to the foot of the beam is going to be from the lateral aspect of the breast to the medial aspect. It places the detector vertically between the two breasts. This projection is very good when you want to really see a medial lesion. It's also good when you're imaging, for example, a non-conforming patient. If the patient has had surgery in the sternum area, it's typically stretches the skin if you try to do a mediolateral, even the mediolateral oblique, and that can be extremely painful for the patient. So this projection is one of the options that you can use when you want to image these non-conforming patients. So this is what the image looks like. You should have an open fold on your mediolateral projection. So it should be a nice, clean, open fold. This projection could also be used if you're imaging a patient and you simply can't get the fold on your mediolateral oblique. So the lateral medial, will give you a nice open fold. You will not necessarily see muscle on your lateral medial, so don't compromise the imaging to get muscle. Remember, the muscle that you're supposed to be demonstrating is on your mediolateral oblique, not on your lateral medial. Now, the mediolateral, this is a more common projection that's done. It's the mediolateral, so the ray is going from the medial aspect to the lateral aspect. So this will also demonstrate medial lesion. This is oftentimes what's used when the radiologist notice something, calcifications on the breast, and they think that this possibly might be a benign lesion, a lesion in the lobules. These are the lesions that will settle in the dependent portion of the lobules and show up on your image as teacup-looking calcifications, proving that they're actually benign. This is also used to verify the location of a lesion. I think this was one of the questions asked earlier on. So if you did your mediolateral oblique, and then you did your mediolateral, and your lesion moves up, then you know it's a lateral lesion. If it's a medial lesion, it is going to move down. The central lesions typically will not move. So medial lesions move up, lateral lesions move down. This is from their position on the mediolateral oblique, and central lesions typically will not move. Now the roll these are positions, not projections. So the roll positions oftentimes will allow you to visualize an area that may have been superimposed on the CC or on the mediolateral. So they have different roles. The direction of the roll is how the imaging is named. For example, if you have your breast and you decided to position CC and you rolled the upper surface of the breast lateral and the medial surface of the breast medial, then you have a lateral roll. And then the reverse is true. If you roll the upper surface of the breast medial and the lower surface of the breast lateral, then it's going to be a medial roll. Some radiologists feel that this is hard to reproduce, and there's recommendation by some that instead of using a roll, you can use a slight 5-degree angulation. Some units also offer the option of angling just the tube and keeping the detector horizontal. And in that case, too, there's a possibility of using a 5-degree angulation to the medial or to the lateral. And that is reproducible, which is why some radiologists prefer that option. Now, the roll can also be done with the patient in the lateral. The patient is positioned laterally. An inferior roll would be rolling the surface of the breast furthest from the detector inferiorly and the other surface superiorly, whereas a superior roll would be rolling the surface of the breast away from the detector superiorly and the lower surface inferiorly. So again, the rolls may not be as common because of the fact that it's difficult to reproduce. How I roll might not necessarily be how someone else's roll, and they will not be able to have that reproduction. Now the XCCM, this is a projection of the medial breast. This focuses on getting the deep medial tissue. Typically for this projection, you try to keep the patient through CC, and then don't tilt, but you turn them so that you get the deep medial portion. Bring the opposite breast onto the imaging plate oftentimes assist with getting that deep medial portion of the breast. Now the XCCL is used to get the far lateral aspect of the breast. In this projection, again, the patient is CC, positioned CC, and then no tilt. You're simply turning the patient medially, so you're getting the far lateral aspect of the breast. And depending on the breast size, you may not actually see any medial breast tissue, as shown in this image. You may not necessarily see breast tissue on the plate. Now the cleavage or CV projection, this is even better at demonstrating the deep medial breast tissue. In this projection, you typically want to bring both breasts on the detector and then you're imaging. You may off-center it a little bit depending on which is the area of interest, right versus left. But in general, you want to see both breasts and it gives you that deep medial tissue. This is also great for patients who may have breast tissue extending all the way into the medial, almost overlapping with the other breast tissue. I see some questions popping up that I'll address them as soon as we finish this section here. Now the AT is to image areas that may not be imaged on your regular MLO projection. So for example, showing here this far lateral area of the breast, you may not necessarily get it on your mediolateral oblique. And here it is demonstrated here. It's missed on the CC, may not necessarily be imaged on your mediolateral oblique. The AT gives that deep tails of Spence area of the breast, and that will get that image. Now, the angulation and patient position is often dependent on the facility. Some facilities will set something, for example, 20 or 30 degrees. Others leave it at the discretion of the technologist. You should not image the head of the humerus, however. What you're trying to do is just go just below the head of the humerus with your detector and pull that in. This is also the position that you can use, the projection that you can use if you have folds in the axillary area because you lifted the breast when you're imaging the mediolateral oblique. So you can use this to image that, to clear up those folds and get a good image of the pec muscle going all the way up into the axilla. So here we have an image of the AT, and again, do not bring the head of the humerus in the image because then you'll not be able to compress sufficiently and you'll get a poor contrast and poor diagnostic quality image. Now this spot. The spot is when you want localized compression in one area of the breast. So you can perform this in any projection. It can be performed with or without magnification. Typically, you want to inform the patient what you're doing and why, because it does feel a little bit tighter compression. And because it's localized in just one area, it can be more painful for the patient. So just let them know what it is they're doing and why it is that you're doing it. There are different spot paddles. There's this very small one, and then this the square paddle that is becoming more and more common. This can image calcifications, and especially when it matched with magnification to show the nature of the calcification. So here we have the other localized compression device and its image. Typically, you need to use proper triangulation techniques when you're doing spot. So you're either going to be looking at the actual radiograph and triangulating the lesion from the CC or the MLO, depending on where it is seen, and then you determine where it is that you're going to compress. Again, showing an area here, compress, and it was a pseudo lesion. It has disappeared on the spot compression. Again, showing an area. And this time, spot compression shows clearly that this lesion is real. It did not disappear. This is something that they would need to follow up on. Now, magnification. Magnification is performed with a larger OID. The breast is raised off the detector. And because of that raised area, that air gap, typically that means that you don't need to use a grid. And so it's not recommended that you use a grid with magnification because the air gap takes the place of the grid basically in cleaning up the image, removing scattered radiation. Typically for magnification to get a good quality image, they use a smaller focal spot size, microfocal spot size for the magnification. It can be done often and is done with spot compression, but it could be done without it. But just remember, magnification may not necessarily image the entire breast, especially depending on the breast size. So it will image a portion of the breast, but not necessarily the entire breast. And it is very good in showing skin margins and for calcification. So here we have the patient in position for magnification, the normal breast, and then the magnified image of this area. Now, implant displaced projections, if the patient has had surgery and they had a breast implant put in place, instead of doing the 4-view series, then this now adds 4 additional imaging. So it's called the Gland or implant displaced projections. So the nature of the implant and type of the implant is going to determine how effective this imaging will work. So here we have this implant is placed in front of the pec muscle. Sometimes that can result in encapsulation. Sometimes it can also be difficult to get any breast tissue because you have very little breast tissue and there's a large implant. So all of these are things that have to be taken in consideration when you're imaging implant. Implant that are placed between the pec muscles are easier to displace. Also, there's less there's less encapsulation of the breast, therefore it is a lot more movable. So here we have this implant, subpectoral or retropectoral implant behind those pec muscles, and then this is in front of the pec muscle. One of the reasons why they're actually bringing back this subglandular implant is the fact that some patients have placing the implant behind or between the pec muscle, they actually is damaging to the muscle. So some people have difficulty after lifting, handling any heavy objects. So this is why there is a trend to put the implant back in front of the muscle. So the technique, typically I will have the patient stand slightly away from the detector and then lean forward. I feel for the edge of the implant. Once I get that edge, then I place the detector at the lower inferior portion, and then I keep my hand at the superior portion and bring the compression plate until it just touches the implant. Once I get that, then I start pulling the breast tissue forward as I slowly compress, pushing the implant back. And the idea here is that you're going to compress totally onto the breast tissue and the implant is pushed back totally out of the imaging field. So this is the implant displaced projection. So this is the initial image. So remember, we're doing 4 with the implant in place and 4 with the implant displaced. So this is the implant in place projection. So you see the implant right here in the image. Now with digital, depending on the size of the implant, you actually may not necessarily need to use manual technique. Just make sure your detector is over breast tissue and not over implant. And I found with digital, even if there's a very, very little breast tissue, say on your implant displaced projection, this is a significant amount of breast tissue here, even sometimes up to just an inch of breast tissue, and you'll still get a good exposure. But of course, if you are not working with digital, or if you don't have enough breast tissue covering any portion of the detector, then you need to set manual technique, especially here, if you are not actually over the breast tissue, you absolutely need to set manual technique because you will actually give the patient an overexposure. Although, yes, with digital, it will correct. You'll see a good image unless you go too far over, but you are giving that patient an overexposure. And you remember with breast imaging, the patient is coming yearly for their mammograms, so you don't want to give them an overexposure unnecessarily. So here we have for the MLO, the same applies. You have the patient stand slightly away from the unit, bend forward. Again, you're feeling for the edge of the implant. Once you've located the implant, use the detector at the lower aspect, and then you keep your hand at the upper aspect until it's replaced by the compression paddle. Then you start pulling the breast tissue forward, pushing the compression as it comes down will push the implant back, and then you get your implant displaced projections. So before you start any implant displaced imaging or any patient with an implant, you find out from them type of implant so that you can document it. Some facilities actually now have the patient sign off on a consent to avoid having possible rupture, that the facility is not responsible. With silicone implants, most of the new ones can take over 300 pounds pressure, so they really should not rupture on the mammography compression. But again, for patient safety, for your protection, you need to make sure your patient is properly informed. So here we're going to demonstrate, we're going to cover a few troubleshooting areas, what to do when we have problems in our imaging. So we're just going to go over a little bit of these. So remember, we are in control of what we're doing here, and we are going to make sure that we have good positioning, good compression. The breast should be compressed until it's taut. We got our perfect CC or perfect MLO projection, and this should have adequate exposure, good contrast. It should not look washed out, nice sharp calcifications or any areas of the breast tissue. There should be no artifact obscuring any detail of your image. With mammography imaging, we don't collimate to the breast tissue, we collimate to the size of the detector. And of course, we're going to make sure that our labeling is standard labeling on all of our images. So this is our checklist. Once we have completed our image, we make sure everything is okay before we submit that image. So this area, a bit of you're not seeing all the way to the posterior retromammary space on this, because you can see there's glandular tissue going here on the CC in the axillary area here. So you know you're not getting the entire posterior breast tissue. So in this case, you probably would need an XCCL just to get that miss area. And again, it depends on your facility. Some facilities automatically say that you're missing tissue. Make sure you cover all of the tissue before you submit everything. Others do have more radiologist involvement before they can do any additional imaging. So make sure you're aware of the protocols at your particular facility. So the nipple is not in profile. The solution, there are various solutions to this. Sometimes when you put the breast on the detector, you'll notice that the nipple tilts up, and sometimes it actually tips down. So once that happens, you know when you're imaging, you're not going to get that nipple in profile. How do you handle that? Depends on your facility. There's some facilities that want you to use a nipple marker all the time. So if you use a nipple marker all the time, you may not necessarily need to repeat. The other option is that if the nipple does not fall in profile on your CC, it will fall in profile with proper positioning on your mediolateral oblique. And the same goes for your mediolateral oblique. If you position and your nipple turns in, folds under on your mediolateral oblique, typically it will fall in profile on your CC. So if your facility says that you need to have the nipple in profile in at least one projection, then you're good to go. There's no need to repeat. You have it there. However, there are some facilities that say that the nipple must be in profile in every projection. Now, in that case, if your nipple falls in under the breast and you're not using a BB marker, you may need to do a nipple in profile projection. What you should never do is try to rearrange the breast to put the nipple in profile. You're going to do your full image, the nipple will not be in profile, and then you do just the nipple area and you have a nipple in profile projection. But as I stress, that is only done if your facility says that they have to have the nipple in profile in all of the projections. So in this case, the nipple is not centered. If the nipple is not centered, it typically turns in the direction of the missed breast tissue. Now remember, the CC is the most important projection for the medial breast. So if you have your nipple turning towards the medial breast, that means you're missing the medial breast. So that's not good. So you definitely will need to do an additional image to make sure you're centered, or at least you cover your entire medial breast tissue. Now, there are a number of things wrong with this. It's mediolateral oblique, and they're probably pulling in a little bit of this skin that is causing this overlapping rigid area right here. So this definitely needs repeat. There's also no inframammary fold. So you need to get a clean, clear, open inframammary fold on this. So this would probably be repeated. Now this is not showing enough pec muscle. You remember you're measuring your PNN line. It should go posterior all the way here and it should hit the pec muscle. So you're not getting enough pec muscle here. You also have some closed folds here. You may need to repeat this. There are too many things wrong here, both with the muscle and the fold. So you probably would want to repeat this. Now, this is showing what you want to have. You want to get this. This is a perfect patient. Are you going to get it all the time? Absolutely not. You may get a vertical fold. I would not repeat a vertical fold. I would also not repeat a concave fold. I would attempt to repeat this because you definitely don't have this to the level of the pectoral muscle. So you'd make an attempt to get some more pec muscle in this particular situation. And one thing of note with these, although this is not necessarily repeatable, this is not something you'd want to submit to the ACR. So the fold must be open on the MLO. Again, is it possible on every patient? Absolutely not. But you do want to try to get an open fold. If you don't have an open fold and there's a lot of folds, skin folds covering your fold, you may want to do the mediolateral. That usually clears it up. And if you have a patient, I think one of the previous questions was that the patient has protruding abdomen and could not image the fold, that sometimes the mediolateral will take care of that too. There's also projection, the SIO, that is not that commonly used, but that I find will also take care of folds because in that case, with the positioning, the fold forward, so you are able to get a good open inframammary. I'm sorry, the abdomen folds forward, so you're able to get an open inframammary fold in that case. This is just poor positioning, poor compression, and needs to be repeated. Something like this you could probably keep to show a patient who is afraid of compression that, something like this is totally undiagnostic, and this is what can happen if you don't compress your breast properly.